eye examination. Before that, we must have a thorough and conceptual knowledge of anatomy of the eye, and not only in eye but in every subject. Until and unless you know the anatomy, you neither learn the physiology nor biochemistry nor pathology. So anatomy is key to the everything. So I'm going to draw the sagittal section of the eye, and I hope कि सबको नज़र आ रहा है. जिनको नहीं आ रहा वो बेशक खड़े हो जाए, लेकिन देखें ज़रूर, बड़ी इंपॉर्टेंट चीज़ है. आप इसके ऊपर ज़रा फोकस रखें, ठीक है जी. ये है कॉर्निया, तो मैं ज़रा छोटी बना रहा हूँ इंटेंशनली, और ये स्क्लेरा. दिस इज द आउटर मोस्ट लेयर. आई बॉल कंसिस्ट ऑफ 3 लेयर्स, ठीक है. अगर आप थोड़ा खड़ा हो जाए तो आई विल बी कंफर्टेबल कि आपको नज़र आ रहा है. तो ये आउटर मोस्ट लेयर है, ठीक है. मिडल लेयर होता है कोराइड, ये मिडल लेयर है, और मिडल ये कोराइड, और यहाँ तक almost 5. This is cornea, this is sclera, this is corneo scleral junction. It is called limbus. Are you getting my point? किस साइड से किस तरह नजर आती है, ठीक है. From limbus, behind the limbus, almost 5.5 millimeter is the vitreous base. That is, वहाँ पर एक स्ट्रक्चर होता है, उसको ओरा स्ट्रेटा बोलते हैं. वहाँ पर होती है सिलरी बॉडी. सिलरी बॉडी इज द कंटिन्यूएशन ऑफ कोराइड. इट इज आल्सो वेस्कुलर लेयर. इस तरह करके सिलरी बॉडी भी होती है, और सिलरी बॉडी की कंटिन्यूएशन है आयरस, और आयरस के अंदर जो होल है दैट इज कॉल्ड प्यूपिल. Innermost layer जोन से that is the retina, which consists of retinal pigment epithelium and 9 other layers which make up the neurosensory retina, like outer plexiform layer, inner plexiform layer, outer nuclear layer, inner nuclear layer. ठीक है, ये आपने पढ़े होंगे, उसकी डिटेल में नहीं जाते. उसके बाद सिलरी बॉडी, फ्रॉम सिलरी बॉडी arise the suspensory ligaments, and they hold the lens, and somewhat here is the optic nerve. Now whenever you perform examination of the eye, torch eye examination, this picture should be stuck in your mind. I will further draw one more thing. This is the upper eyelid, साइड से देख रहे हैं ना, and this is the eyelash. It is a schematic diagram. Okay, this is the lower eyelid. Are you getting me? Are you getting my points?
Yes, sir.
This is the lower eyelid. जिसको समझ ना आए ना, please stop me, let me know so that I may try to clarify that. This is the lower eyelid. Now you can see I have intentionally made the eyelash going upward, outward and upward, and lower one outward and downward, because if the reverse happens then it is called trichiasis, misdirection of the eyelashes, which we will learn in the torch examination. So this is the you can say a schematic basic anatomy of the eye. This is cornea, this is anterior chamber, this is iris, this is pupil, this is anterior chamber and this is posterior chamber. This is lens, this is sclera, this is choroid, this is neurosensory. Okay, now we come to इस तस्वीर को मैंने इसलिए यहाँ पर बनाया है कि now we come to the torch eye examination. Whenever you do the torch eye examination, I think the video will be so long because first of all I'm going to tell you the theory and then I will perform it. So I think you should pause it here. आज ट्रांजिट है ना 1 2 3 4 5 6 मैं ये अज्यूम करूँगा कि आपको टॉर्च एग्जामिनेशन आता है और मैं ये पूछूँगा भी बाद में आपके फायदे के लिए है, ठीक है? लेट्स स्टार्ट। अस्सलाम वालेकुम, मेरा नाम डॉक्टर शाहजाद वसीम है। आपकी आंखों का मायना करना है, आपको इसमें कोई तकलीफ नहीं होगी। आज इजाज़त है। Let's start the examination. अच्छा इसमें एक तो पॉज मुझे फोकस करें और जो मैं चीज़ कर रहा हूँ उसको फोकस करें। अगर कभी आ भी जाए ना आप लोगों की तो मैं उसका बैकग्राउंड चेंज, आजकल आपको पता है बड़ी एप्लीकेशन से बैकग्राउंड चेंज कर देता हूँ। अच्छा तो फर्स्ट ऑफ ऑल वी विल टॉर्च की दूसरी है। So let's start the torch eye examination. First of all, after taking the consent, I am just checking the general positions of the eye, any growth on the eyelid or in the vicinity of the eye, that is periocular area, the posture of the head, any abnormal head posture. Patient may see in a treated manner, which may be because of some nerve palsy or chin up or down, which can happen in chin up, occurs usually in ptosis. And after a general inspection, I will now start the specific eye examination or specific torch eye examination. And first of all, आंखें बंद करें. Now I am looking at the eyelashes and I can see they are nicely coming outwards and upwards, upper eyelid, correct? And the lower ones are outward and downward. What are the possibilities? There is a possibility that the eyelashes of both eyelids, upper or lower, turn inside. It is a condition which is called trichiasis. Trichiasis causes a little. Now I have मजबूरी है little bit of theory जो सी वो भी आपके साथ बतानी पड़ेगी. Trichiasis is the misdirection of the eyelashes and it will irritate the cornea and the conjunctiva and it will cause patient feeling of foreign body sensation and increase lacrimation, increase production of the tears. And there is no such thing that I can see the margins of the eyelid. They are well in position. They are not everted. That is, there is no ectropion. They are not inverted. There is no entropion. These things you have already learned. After eyelashes, I will see the conjunctiva. Now the conjunctiva which I can see right from the. Is it focused right?
सर यहाँ से इस पे नहीं होगा.
The conjunctiva which नजर आ रहा है सबको इधर बैठ जाओ. Which you can see is the bulbar conjunctiva. There is no growth in the right eye, but there is small, very small growth in the left eye. You know? There is very small growth in the left eye on the conjunctiva, and it is most probably pterygium. Pterygium is the conjunctival degeneration, and the most common cause of pterygium is ultraviolet rays, which we see from the sun. So people who used to move more in the sunlight, they may develop it, but it is very innocuous, doesn't cause any problem other than UAV. So one there is one positive finding. There is a small pterygium. इधर देखे जरा. Can you see?
तो किधर?
इधर देखे. This fibrous band coming on the sclera,
जी.
yellowish color and encroaching on the cornea. इधर देखे side. ये.
अच्छा.
And this is the bulbar conjunctiva, and in the left eye conjunctiva there is pterygium. Now I will see the pulling the eyelid downward. I am looking the fornical conjunctiva, the second part, and the third part is palpebral conjunctiva. Before that I will ask the permission. मैं आपकी आँख थोड़ी सी टर्न करूँगा, थोड़ी सी तकलीफ होगी. नीचे देखें. Now I will नीचे देखें. थोड़ी ऊपर करें, थोड़ी ऊपर करें. अब नीचे देखें, थोड़ी सी नीचे करनी. With practice you can easily do it, but sometimes structural uh, differences in people makes it difficult, and you can take the help of the pencil or thermometer and invert it and see the conjunctiva and meibomian glands. And intention is to see any growth, some like or any hyperemia of the conjunctiva, any discharge or anything like that. After conjunctiva, I'm trying to go slow and slow so that your mind may register what I'm talking, because in the previous batches I have seen that when I go fast, you people forget the things. So I've got the time today. Same is the case in the lectures. I have to go fast. Here we have the time. After eyelids and eyelashes, what next? And we have checked the conjunctiva and sclera. Sclera is the structure which you can see white. Previously I was calling it conjunctiva, but actually it is sclera which you are looking through the transparent conjunctiva. Conjunctiva is transparent, but it has blood vessels, and sclera, this whitish structure is sclera. And in sclera we will see all four quadrants. This is nasal part, this is temporal part. इधर देखें. अब मैंने इसके देखा, टेम्पोरल देखा, इसके नेजल देखा. इधर देखें, नीचे देखें, ऊपर देखें. ठीक है. स्क्लेरा में व्हाट आई हैव सीन, एनी इंफ्लेमेशन, एनी नोड्यूल, एनी थिनिंग. Most commonly the patient who can develop the disease of the sclera is scleritis, most common. It can be a sectoral scleritis, that is just at one part, or it can be diffuse scleritis, that is all the sclera is involved, or it can be nodular scleritis. It can be in the form of nodule. So after the sclera is okay, there is no problem. Now we move forward. Now we come to the cornea. Now cornea and sclera both are made up of the proteins. Now why cornea is transparent and sclera is not? Because one theory is that the collagens of the cornea are placed in a special pattern. For example, one lamella is like this, 1, 2, 3, 4, and the other lamella is like this in a pattern. So the other one will be like this, and the other one will be like this. This makes the 5 layers of the cornea, and this placement of the collagens in the cornea supposedly uh, does the process of diffraction, which makes the cornea anatomically transparent. And in sclera, the placement of collagen fibers is haphazard. It could be like this or this. There is no pattern, so it makes it visible and not transparent. While examining the cornea, our main concern is to see the transparency of the cornea. If cornea is not transparent, there is some pathology. And what makes cornea transparent? Number one, anatomical uh, structure, as I told you. Number two, physiologically, as you know, there are 5 layers of cornea. The fourth one is the endothelium. Endothelium contains sodium potassium pump. It continuously works and throws the water of the aqueous humor out of the cornea and make keep it transparent. If some inflammation occurs in the anterior chamber, that is anterior uvulator, so if decimal membrane is damaged, the this barrier is damaged and cornea becomes edematous and loses its transparency. Okay, and now you can see while I am putting the light, I can't see the cornea. I can see the iris and the pupil. This is a normal finding. Uh, does anyone of you have a wristwatch? Anyone? नहीं, कोई दूसरी वाली जिसपे हाँ ये देखिए cornea is like you can say like a wristwatch. ठीक है, the आपको इसमें जो नज़र आ रहा है, आपको इसमें इसकी सुइयाँ नज़र आ रही हैं, इसके नंबर्स नज़र आ रहे हैं, बस लेकिन जो आगे शीशा लगा हुआ है वो नज़र नहीं आ रहा. शाइन पड़ती है तो नज़र आता है, वरना नहीं आता. अभी इधर से देखें ना तो नहीं आ रहा. दिस इज जो नज़र नहीं आ रहा, दैट इज कॉर्निया. अगर उसके ऊपर ओपेसिटी है कोई, या अगर आपको पीछे से नंबर नज़र नहीं आ रहे, तो इन दिस केस इफ आई कांट सी द आइरिस or if I can't see the pupil, it means if one of the causes can be that at that place cornea is opacified. जैसे इसके ऊपर स्क्रैच भी पड़ जाता है, अगर ये स्क्रैची हो जाए, जैसे patient might had some infection of the cornea, he had corneal ulcer. After resolution, the corneal ulcer converts into corneal opacity, and the corneal opacity causes the loss of transparency, and you can't see anything beyond cornea. Okay, so cornea is transparent. You will measure the size of the cornea ideally. It is 10.7 millimeter vertically and 11.6 millimeter horizontally almost. You can say 10 to 12 millimeter is the diameter of the cornea. There is a normal diameter of the cornea, no opacification, and no other finding is found. Next, anterior chamber. For anterior chamber, You will see from the side. Ask the patient to see straight ahead. From the side, you will see a space, and it is a small cavity, and it is bounded anteriorly by cornea, and posteriorly is the what? Iris.
Iris.
The space between the cornea and the iris
Iris.
is the anterior chamber, which we see from the side. And what we see in the anterior chamber, हम दोनों साइड्स पे जाके देखें, ठीक है, ठीक है। एक तो आपने ये देखना है कि टॉर्च एग्जामिनेशन में ग्रॉसली sclera is shallow or deep. Usually it is difficult to appreciate in normal people, but if for example if this patient is 70 years old and has undergone the cataract surgery and lens is not placed, artificial lens is not placed, and it is aphakia, the lens will be the anterior chamber will be deep, and because there is no lens and there is no structure behind as compared to the other eye. Similarly, difficult to appreciate, but with practice you can. In myopic eyes, the eye is large. Myopic eyes, the torch is the eye is enlarged. Therefore, the anterior chamber is deep as compared to myopic eyes, which have got the shallow region. As we see in the anterior chamber is the presence of blood, which is called ephema. We have to see pus, which is called hypopyon, and hypopyon's most common cause is post-operative after cataract surgery, which is called endophthalmitis. And there are some corneal ulcers which are especially pseudomonas. They cause pseudomonas corneal ulcers. Besides corneal ulcers, there is hypopyon. These are the things which can be appreciated on the torch. After that, you will go to the iris and pupil. You will see the color of the iris of both eyes is same. आप आँख ना मूव करें, ये मेरे नाक की तरफ देखें, and इधर देखें, नाक की टिप की तरफ देखें, and there are no signs of corneal there are no signs of iris inflammation, that is uveitis. How we can detect that the patient had an attack of uveitis 10 years back? Pupil will not be round, first of all. Okay? In some cases, we see specific structures like Cope nodules and Basaka nodules. These are in granulomatous inflammation, and they resolve after uveitis is resolved, but Cope nodules sometimes still are present. But pupil shape is very important. It must be round. If it is not round, there is something wrong. Now we come to the pupil. What do you see in the pupil? You know, the pupil is an aperture or hole in the iris. So, what we will see? We will see first of all the color of the pupil. It should be black. What are the possibilities? It can be white, most common. What are the possibilities of white pupil? What are the white pupil is called leukocoria. Okay, and differential diagnosis of leukocoria. The causes are most common cataract, retinoblastoma, which is a very serious disease. The most common intraocular malignancy in children under the age of 2 years is retinoblastoma. In retinoblastoma, as it is present on the retina, its reflex produces the pupil to appear as white. Then there are many other causes. A couple of causes are chronic endophthalmitis going on the retina, or PHPV, persistent hyperplastic primary vitreous. So you must remember these causes. I will not go in the detail of the theory. So the color of the pupil is very important. The main important thing is, and out of these, the cataract and retinoblastoma are very important, especially if the congenital cataract, the child comes, the first thing the ophthalmologist fears that it is could be retinoblastoma, and for that we have to take out the eye, enucleation, which is very it is vision threatening to have, but it can be life threatening. After this, we will do the pupillary reflexes. I will now going to perform the, as you were saying that the visual pathway and the other one was the light reflex. Light reflex means we are going to check the pupillary reflexes. We have supposedly know the theory of light reflex. I will perform how to check the pupillary reaction. Before that, you will give special commands to the patient, and at your end you will do some things. You will ask the patient to see far. वो आप सामने आप स्नेलिंग चार्ट नज़र आ रहा है ना, उसके सबसे ऊपर जो लेटर है, जो टी लिखा हुआ है, उसकी तरफ देखें. ठीक है. This is will relax the patient's accommodation, and by looking at a near object, because of accommodation, the pupil becomes myosed. So I have asked him to see far so that the pupil becomes at its normal shape. Secondly, you will dim the light of your room, not in this highly lighted room. Pupil will be myosed. You will dim the light and pupil will be in the normal position. Then you will bring the light like this, not like this, from side, and I am looking the same eye on which I am putting the eye, and the pupil is reacting. And then I am going to check the direct reflex on the other eye, and pupil is reacting. How we check the consensual reflex? We place the hand. I am telling there are many other methods also. I am telling the method which you are used to be. Place the hand not like this, so that the light doesn't pass through my hand. I will pass the light on one eye and see the other, and then I will pass the eye on the other eye and see the other. Both pupils should react. Understood? This is indirect pupillary reflex or consensual pupillary reflex. What happens theoretically? The fibers which are coming from the optic nerve, some fibers go to the lateral geniculate body instead of going to the visual cortex, and from lateral geniculate before lateral geniculate body they go to the at the midbrain in the adrenal westphal nucleus, not lateral geniculate body. Before lateral geniculate body, at the midbrain, at the level of the superior colliculus. They go at Edinger Westphal nucleus, and from Edinger Westphal nucleus they go to the pretectal nucleus of both the eyes. Now this point, that pupillary fibers from Edinger Westphal nucleus to pretectal nucleus, which is present just in front of the Edinger Westphal nucleus. याद है ये Edinger Westphal nucleus है, for example this is pretectal nucleus. They will go here and they will go to the other eye also, and this double wiring, I would say, जो यहाँ से उधर भी जा रहे हैं, these fibers are responsible for consensual reaction. If there is some lesion at the pretectal nucleus, the consensual effect will be absent. From the pretectal nucleus, they go to the third nerve, which is called a oculomotor nerve. A oculomotor nerve goes and its branches, ultimately, I will not go in detail of the names of the branches. The end branches go to the sphincter pupil, and they will cause the constriction or dilatation of the on the muscles of the sphincter pupil, not the dilator pupil. Okay, this is the light reflex pathway and pupillary pathway. Understood? You need to practice these things. What next? Now, lens. How will I see the lens? आप सामने देखें, वो वही इस तरह चार्ट पे pupil dilate हुआ. I can see behind the pupil. Can you people see the reflex of this torch on the cornea of this patient? आ रहा है नजर में? इसी तरह का एक छोटा सा रिफ्लेक्स लेंस के ऊपर नजर आता है, जो ट्रांसपेरेंट होता है. वो परकेंजर सेंसर इमेजेस होते हैं, उसकी डिटेल आप बेशक पढ़ना चाहें तो पढ़ लें. उसकी वजह से होता है, वो लेंस के ऊपर पड़ता है, बहुत छोटा सा, वो आपने देखना होता है. अगर वो नज़र आ जाए तो ट्रांसपेरेंट होता है, अगर वो नज़र ना आए तो इसका मतलब है कि वाइट कैटरेक्ट है, तो वो के साथ इंटरमिंगल हो जाएगा एंड यू विल नॉट बी एबल टू सी द लेंस. नाउ टॉर्च वी विल, हम टॉर्च एक तरफ रख देंगे और इसके बाद जो 3-4 चीज़ें रह गई हैं वो करेंगे. First of all, digital tonometry. How will we assess the intraocular pressure? This is a very crude method. आप मेरी कमांड सुने, नीचे देखें, सर थोड़ी नहीं नीचे करें, नीचे देखें. आप you will place all your fingers on the forehead एक्सेप्ट इंडेक्स फिंगर्स, शहादत की उंगली, उसको अपर लिड पर रखें और ऑल्टरनेट प्रेशर दें. फिर इधर करें, फिर ऑल्टरनेट करें. इस तरह नहीं करना. देखें, ये मिस्टेक स्टूडेंट करते हैं. एक उंगली एक आंख पे, दूसरी पे, एक पे रखनी है. सब इस तरह करके, इस तरह फ्लक्चुएशन. यू विल feel whether it is soft or it is hard. If it is hard, then you should think that the intraocular pressure is increased and you should think about possibility of glaucoma and send the patient for more sensitive and sophisticated test, that is applanation tonometer. Okay, we will हम आपको बाद में दिखाएंगे इसका. If eye is soft, it is normal, but if his eye is very soft, then it is a matter of concern. there can be many things. For example, in retinal detachment, there is tear, eye becomes soft. If there is a history of trauma, eye will be soft. So these are the things which you check up on the digital tonometry. Don't do the mistake of placing each finger on separate eyes. Place the both fingers on the same eye and do the fluctuation. And this is only you can do with practice. At your level, it is not possible to tell what could be the normal pressure. But after 15-20 years of doing this practice, you can assess the pressure is high or low. Next test which we will perform is regurgitation test. It will tell us the status of the lacrimal system. For this, we will, if I am going to check the right eye, I will place my hand on his head to stabilize it. I will place my index finger 2 millimeter behind, 2 millimeter below the medial canthus. यहाँ पर 2 millimeter below the medial canthus. My index finger. What lies here is the lacrimal sac. It is applied anatomy. I will place my इंडेक्स फिंगर, चले मैं इस पे करता हूँ, ज़रा कंफर्टेबल हूँ. उसके बाद मैं थोड़ा सा इसको इवर्ट करूँगा. नाउ आई कैन सी द पंक्टम. कैन यू सी इट? क्लोज करें इसको क्लोज करो ना यार. इस
कर.
अच्छा, तो ये पंक्टम को अब नज़र आ रहा है. अब मैं आई विल प्रेस द लैक्रिमल सैक. Nothing has come out of the punctum. The regurgitation test is negative. It means the lacrimal system is patent. If some fluid regurgitates back, then I would say that it is it can be dactyl cystitis, or most commonly it is nasolacrimal tract obstruction. अच्छा, हमने डिजिटल टोनोमेट्री कर ली, हमने regurgitation टेस्ट कर लिया. उसके बाद एक्स्ट्रा ऑक्यूलर मूवमेंट्स. पेंसिल देना जरा. जिस तरह आप लोगों ने एच बना के किया ना, एच बना के किया होगा, तो मैं उससे ही बनाता हूँ. इसकी टिप की तरफ देखिए, कोई ऐसा दे, दूसरा दे. अपने पेशेंट को टारगेट जरूर देना है. इतनी नज़दीक भी नहीं करना, इतनी नज़दीक भी नहीं करना. आर्म्स लेंथ पे होना चाहिए. यू आप और एग्जामिनर और मिड वे पे होना चाहिए ये. ठीक है
जी सर. नहीं सर, कर.
अच्छा, इसको देखें. जहाँ पर आपको दो नज़र आए या दर्द हो तो मुझे बताना है. ठीक है, यू विल काउंट पोजीशंस. ठीक है, राइट गियर, इसके नाम भी हैं मुश्किल नाम, जैसे ये डेक्स्ट्रो वर्जन है, ये लीवो वर्जन है. उनको आप बुक में पढ़ लें. लेकिन अभी इधर मैंने किया गियर्स नंबर, इधर देखें ना, पेन इधर 1, गियर्स नंबर 2. ठीक है, गियर्स नंबर 3. फिर सेंटर में लाए या इस तरह ले आए. ये मैच में ला रहा हूँ. 4. अब नीचे देखेंगे ना, जब भी आपने आंखें आईलिड नीचे उठानी है. नीचे देखें आप इसकी तरफ, क्योंकि आप लिम्बस देखना है यार. इसकी तरफ टिका के देखें. ठीक है, नंबर कौन सा है? 5. उसके बाद इधर देखें, ये कौन सा नंबर है? 6. उसके बाद आप सेंटर में आ जाए. एलिवेशन, ये नंबर 7. नीचे देखें, डिप्रेशन. इधर देखें, इधर देखो यार, नजर नहीं आ रहा. कितनी हो गए? और ये सेंट प्राइमरी पोजीशन कितनी होगी 9 यू हैव टू चेक द एक्स्ट्रा ऑक्यूलर मूवमेंट्स इन 9 पोजीशंस जो मैंने शुरू में कहा था दो नजर आए या दर्द हो तो मुझे बताना उसकी रीज़न ये है कि अगर इसको थोड़ा सा नर्व प्रेसिज हो जैसे 6th नर्व 3rd नर्व या पालसी हो तो वो मसल काम नहीं करेगा तो भी वो दोनों आई बॉल एक तरह से मूव नहीं करेंगे तो यू विल हैव टू फ्लो एंड इन अप गेज if patient has got optic neuritis superior rectus muscle and optic nerve share the common facial sheath do you remember so the movement of the superior rectus muscle will cause the optic nerve is optic neuritis it will cause pain because of that now we come to the last part of this examination and that is confrontation method of visual field checkup. What you will do on the arm distance, ask the patient to, for example, I am checking the visual field of his left eye. He will keep open his left eye. I will open my right eye, the eye which is opposite to that, and we both will close our other eyes. He will close his eye with the hand. इस तरह नहीं उंगलियों से नजर आता है इस तरह आराम से सीधा रखें मैं चूंकि एग्जामिनर हैज प्रैक्टिस वो हाथ से भी कर सकता है वैसे भी कर सकता है अब मैंने इसको इस्तेमाल कर दिया नाउ यू विल नॉट मूव द आई ओके आपने मेरी आंख में देखना आई एम लुकिंग इन हिज आई व्हेन यू सी माय फिंगर लेट मी नो कैन यू सी no you're looking at my finger look at my eye can you see
Yes, sir.
now
Yes, sir.
अब हैं
नहीं
ऊंचा बोले
नहीं लगा
नहीं आ रही अब जब आना शुरू हुआ बताएं
सर
आ रही है
जी
ठीक आपने यहाँ तक लेके आना सेंटर में और छोड़ देना जहाँ फिर अगर ये गायब तो नहीं हुई अंदर ठीक है अब मैं इधर से आ रहा हूँ ये सुप्रो टेम्पोरल था ठीक है अब ये इंफ्रो टेम्पोरल आ रही है नहीं आ रही अभी
आ रही
अभी
आ रही
अभी
आ रही
अभी
जी
ठीक है अब मैंने ये वाली आंख बंद की हुई है ठीक है अब इधर से मैं चेक कर रहा हूँ ये है सुप्रोनेजल आ रहा है अब
जी
अब नाउ इंफ्रोनेजल आ रहा है आ रहा है आ रहा है okay that's it this is the confrontation method of visual fields by which we crudely check the visual fields and the fundamental principle of this is that we assume that the visual field of the examiner are okay if the examiner is himself is suffering from visual field defects then this cannot be performed number one number two is that you saw that I move a picture my finger in oblique manner not in horizontal because the glaucomatous this is very important point and perhaps this will be the last two lines नहीं last two lines of this torch examination very important points if someone wants to write they may write it visual field defects can happen because of two problems number one glaucoma number two neurological disorders like pituitary adenoma. The main difference between neurological and phleochromatous defects are that the neurological real field defects most of the time usually they respect the midline, that is they do not cross the midline. As you can see, there is a bitemporal hemianopia, they are not crossing it. But in glaucoma, the real field defects do not respect the midline. They may cross from temporal to the nasal stem. So, as we are checking the eye, we don't know he might be having a neurological disorder. So, by placing the finger oblique, you not only check the horizontal meridian but vertical meridian also. So, both the factors are being checked. This is your torch examination, in which other 4 tests are also included, and these are the skills which almost 80% of the course is covered if you know this. Thank you very much.